first meeting of the year, I think it's appropriate for me to say Happy New Year to everybody. As our tradition before, we'll be talking about a very interesting, down-to-earth topic, very necessary topic for all pediatricians, fluid therapy in sick children. Before I go on to say more on the topic and introduce the special speaker for today, I want to hand over to Dr. Lawal for his opening remarks.
Okay, thank you very much, Dr. Dudu. I join him in welcoming everyone and wishing everyone a happy and prosperous 2023. I hope I'm audible.
Yes, sir, you are.
Okay. It's a pleasure to also acknowledge and welcome Professor Chris Esezobor in our midst. He's going to be discussing one of those acute hands-on topics in pediatrics, which many people were able to get around it by having a vademecum in their pockets. I hope he will make it so much simpler today that people will not be having to carry vademecum. Do people still carry vademecum, or is it all on the phone now? Anyway, so it's a pleasure to welcome everybody and to especially acknowledge Chris. I look forward to a very interesting presentation on a very important topic because it has to do with acute pediatrics, and it's also hands-on. So thank you very much. Over to you, Dr. Dudu.
Thank you very much, sir. So like I mentioned earlier on, we'll be talking about a very interesting topic, fluid therapy in sick children. And we have no other person but Professor Chris Esezobor. I will try not to call him Chris a lot because we have come from a long way, Chris and I. So I'll try not to use any of the familiar names I know with him, but I'm so happy that Chris is the first. In fact, there's some interesting coincidences here. Chris was just made a professor a few months back. So, and he's using, this is the forum for him to ventilate, as they say it in medicine, his knowledge in educating us on this very important topic, which we encounter daily as pediatricians in our regular practice. Chris Esezobor is a professor of pediatrics at University of Lagos Teaching Hospital, but he began his medical education in the University of Benin, where we were classmates. Then he went on from there to go through residency in Louth. If you say scholars are born, Chris is one of those that are born scholars. Others have made themselves scholars, but Chris, from medical school till date, until all through his residency, proved himself to be, very, how would I the words to use now, not to overlay on the superlatives, excellent scholar, brilliant student, and achieved all the achievables in terms of accolades in the residency program. I keep saying to him that one of the things that he has not achieved is the benefit of failing an exam in pediatrics. He never failed any of the exams all through residency. So in that one could say we surpassed him in knowledge because we had done the things many times, but Chris doesn't have that joy or that pleasure anyway. But so that said, I'm sure we're going to have a very nice time when being a very versatile published author, local and international journals. I was so happy that in his presentation, he had chosen this very, very relevant topic, which we are all going to benefit from. And I'm sure at the end of this topic, we will all be very happy that we have participated in this session. So without much ado, because Chris has lots of things to say, I want to hand over the stage to Professor Chris Esezobor. Chris, over to you, please.
Thank you, Uncle Leo, as we call him. for the very kind introduction. I also want to thank the Guild of Pediatricians in Private Practice for this platform to share knowledge and to discuss. I know it's taking a while. Dr. Leto had been on my neck. Dr. Waje had been on my neck for several months last year to come and talk about this. I'm happy that today we will be able to do that. And so I was given this, I was asked to come up with a topic. And so I went for this. And the reason why I chose this topic is evident from what Dr. Mobolaji Lawal just said. This is something we have to contend with every day when we attend to sick patients, acutely ill patients. And over time, is one area of management that we do not seem to pay so much attention to when it comes to choosing, for instance, antibiotics. We are particularly very careful about the dose, about the route, about the frequency. When it comes to so many other things we do for very ill children, we tend to be very, very conscious about it. When it comes to fluid, how much we give, what route we administer the fluid, what type of fluid we give. More often than not, we don't seem to pay as much attention to it as it would require. But we all know that fluid therapy plays a crucial role in the outcome of any sick child. In the outcome of any sick child, the fluid therapy is crucial. And I'm going to share the next tens of minutes with you. I'm just going through some basics, reminding us essentially some theories underlying what we do. What this slide is trying to show us is that virtually every child that comes our way acutely ill may require a particular type of fluid. The composition may be more of water, less of salt. Sometimes maybe less of water, less of salt. Sometimes maybe more water, less of salt, and various combinations. That's what this slide is essentially trying to say. That please, whenever you attend to any sick patient, either as an outpatient basis or you need to admit, you need to pay attention very closely to the fluid because the outcome largely also depends on this. What this confusing slide is showing is that fluid therapy, especially maintenance fluid therapy, and more so the composition of that fluid has been well researched. We have a lot of evidence from high quality randomized control trial and meta-analysis specifying to us that when children need maintenance fluid intravenously, these are the type of fluid you should give, and these are the ones we shouldn't give. The evidence is quite heavy on the type of fluid, not so on the volume or sometimes on the rate of administration, but on the type, the evidence is heavy, and I'll try and share some of those. So what is the objective, or what are the objectives of today's meeting? We will spend some time reviewing body water, the component, the compartments, and the composition. I will try to make a distinction between tonicity and osmolality when it comes to intravenous fluid. And then we will try and calculate the volume of maintenance fluid we require, and then to provide a scientific rationale for the choice of maintenance intravenous fluid. So this is what I try to do. It's a little bit difficult deciding what to cover, but I think by the time we cover this and the question and answer, we would have, we would sufficiently have enriched and reminded ourselves. So I am going to launch a poll at this stage, and I would like you to put your response. you can see the poll, let me know.
Yeah, we see now.
Good. So we have 3 questions here. The first question is, in your practice, what do you do? So if you have a 6-month-old child admitted for surgery, elective surgery, and the child needs to be placed on nil per horis, which fluid would you give the child? One option there is oral rehydration solution. The next one is intravenous normal saline, intravenous Ringer's lactate, intravenous 5% dextrose water, 4.3% dextrose in 0.8 saline, 5% dextrose in 0.45 saline, 5% dextrose in normal saline, intravenous Ringer's lactate with 5% dextrose, and on. So some people have started answering. Only 2 of the 3 of the 75 participants. So please respond to those. Just click on your answers on your devices. In your practice, what
click on it and it shows, because we're clicking and it's not moving.
I didn't hear that.
Please, you just click on the answer.
Choose your answer, yes. You are voting. This is voting.
Yeah,
so we are doing a trial before the presidential election in February. You have 3 questions there. So please scroll through it on your screen, on your device. Scroll through it and answer. The options are the same, but the questions are different. So I want more people, 19, 20, 22 people have responded, 23. So what do you currently do? We spent 2 minutes, 6 seconds. So maybe I give, I'd like to know what we do. So I'm going to just probably leave it for 4 minutes so that we have a minute plus for each of the questions. There are 3 questions, 3 scenarios. One is a child on nil per horis going for surgery. The other is a toddler that has lost 7% of the pre-illness weight because of diarrhea. And the third one, it's a 12-month-old child with deep breathing, reduced urine output lethargy, and a capillary refill of 4 seconds. The question is, which of the fluid do you use in your practice for children presenting with this? I would say for the last question, what would be your initial fluid you would give? So I have like 30 seconds before I end the polls. Almost 50 participants have responded, 50 of the 81 participants. So that's good. Let's keep going. I will extend another 30 seconds. "57 participants have responded.
I'm happy for him.
Okay, so I'm going to end the poll. So we have 60 of the 86 participants have indicated what they do. So I've ended, and if you can see, these are the results. Maybe somebody for the first question, somebody would tell us I can't see it here. Somebody will probably tell us. Okay, for the first poll, the majority said they will give Ringer's lactate with 5% dextrose. Some said they will give only Ringer's lactate. One said 5% dextrose water. 16 said they would give 4.3, another 12. So about 28 said they would give 4.3 dextrose in saline and 5% dextrose in 0.18 saline and in 0.45 saline. For the second child, 43% said they will give oral rehydration solution, and about 35 said they would give Ringer's lactate. And for the last question, the vast majority, 61 out of the 60 participants that responded, said they will give either normal saline or Ringer's lactate. So thank you for sharing your views with us. Good. So let's keep that in mind. So this is just the poll we just went through. So let's start with body water. So water is the most important solvent, like we all know, and a big proportion of our body weight is water. And usually by 1 to 3 years, that approximates about 60% in children. And by adolescents, females tend to have less body water than males. And so for most of our calculation, we'll be using 0.6 times the body weight to get the total body water. So if a child weighs 10 kg, that means that child has 6 liters of water in the body. The importance of this, water being a big proportion of our body weight, is that serially weighing a child is a good measure. One, to check the hydration status of the child, whether the person is dehydrated or whether you are winning with your resuscitative measures. So when we have patients, for instance, in the hospital, one way to keep a good hand on the level of hydration is to weigh the child serially. Here, what we're trying to show here is that body water is divided into 2 compartments. One compartment is bound by cell membranes, what we call the intracellular compartment. Another compartment is outside the cell membrane, and here is what we call the extracellular. After some few months after birth, the intracellular compartment becomes the most dominant compartment. In the intracellular compartment, that is the body water inside cells, potassium is the major cation, and the anions are this. The osmolality in health is about 280 plus or minus 10. In the extracellular fluid compartment, we have plasma and interstitial fluid majorly. And here, sodium is the major cation. Potassium, like we know in serum, is only 4 milliequivalent. So sodium is the major cation. The major anions are chloride and bicarbonate. Because sodium is monovalent, for every sodium positively charged ion, we have a negatively charged ion. And so if we know the amount of sodium, we can easily infer what the amount of anions are. Again, in health, the osmolality is 280. I have put some arrows here to show here water can cross the cell membrane. The cell membrane separates the intracellular fluid compartment from the extracellular. So the cell membrane helps to what is it called? Separate the two. Water can cross easily. However, small molecules, especially when they are charged, cannot cross. small molecules, charged small molecules cannot cross. So sodium cannot cross from the interstitial fluid compartment into the cells, except it is carried by a transporter like the sodium potassium ATPase, which usually actually brings it out of the cells. Here we have this arrow indicating that between blood at the capillary level and the interstitial fluid, small molecules can pass. Small molecules can pass from blood into the interstitial fluid, but big molecules like albumin do not easily cross. I just want us to have this in mind. The one implication of this is that when large number of cells get lysed, either via intravascular hemolysis or things like tumor lysis syndrome or rhabdomyolysis from crush injury, then we can have large amount of potassium and phosphate inside plasma. What I commonly ask my students is that blood is which one? Is blood extracellular or is intracellular? If you think you have the answer, you could raise your hand and I'll be happy to call you. Blood, is it extracellular or intracellular? Feel free, let's have some discussion. Is blood intracellular or extracellular? Nobody is willing to answer. Otugeme, please unmute. Blood, what is it? We'll make some important points if we get some people to respond. Who is willing? Nobody.
I am willing.
Okay, what do you think? That's Elkanah.
Yes, sir.
Thank you.
Well, it's difficult. I will say plasma.
We can barely hear you.
Plasma and serum, I'll consider them extracellular.
Extracellular, okay.
Plasma, yes.
Okay.
But for blood is a composite, so it's difficult to classify it as whether it's cellular or intra or extra.
So which one should we take now? Extra, intra?
I'll go with extra.
Extra, okay. Dr. Inena, you can unmute and tell us what you think. Dr. Inena, okay. We didn't hear that. You don't mind repeating. Okay. Okay, so blood, let's look at blood. Blood is plasma and cells. So blood is a combination of both intracellular and extracellular. The fluid inside the red cells, the white cells, the platelets constitute intracellular, and the composition would be similar to this. And that's why when we have intravascular hemolysis, we end up with hyperkalemia, hyperphosphatemia. The plasma is extracellular, and so the plasma is this. So most of the fluid changes we are going to see in practice actually happens in the extracellular. Most of the fluid changes, especially when it is acute, occurs in the extracellular. So let's keep that in mind. The first thing we'll talk about is water balance. How do we gain water? How do we lose water? Essentially, we all gain water by drinking. If you don't drink, you have little or no water. The next process of getting water is by the oxidative process. If you remember the Krebs cycle, the tricarboxylic acid cycle, the electron transport chain, you know that when ATP is being produced, you end up with some amount of water. So oxidative processes in the body produce water, but most of the water we gain is by drinking. And we drink when our thirst center is stimulated. Our thirst center is stimulated by two major physiologic stimuli. One, an increase in the plasma osmolality, or a decrease in the plasma volume. A typical example is when, for instance, a child is severely dehydrated or moderately dehydrated. You may find that the child is eager to drink because the plasma volume has dropped. Or a child with undiagnosed diabetes mellitus, because of the increase in plasma osmolality, you find that they become thirsty. So those are the two major stimuli for drinking. Habits also come into this. We lose water through three means majorly through the kidneys. But I want to emphasize the water we lose through the lungs and the skin. The water we lose through the lungs and the skin, most times we are not aware of it. And so we call it insensible loss. It's imperceptible. You know, when we take in air, the air is usually dry. The upper airway tries to add water to it through the process of humidification to make sure that the air is suiting to the lower airways. And then when we breathe out that same air, we're taking away water. And so we're losing a lot of water. So when children are tachypnic, they're also losing water. When we are hot and sweating, we're losing a lot through our skin. So we call that insensible loss. And then pathologic processes could occur with how we drink water, and pathologic process could also occur with how we lose water. And if loss is more than gain, then we become dehydrated. And if we're gaining more than we're losing, then we become hypervolemic. It is important we remember that we can calculate the insensible loss per day using the formula 400 to 500 ml per meter square. So if somebody's body surface area is 1 meter square, that means in a day, under normal situation, we expect the person to lose between 400 and 500 ml. In a very hot environment, I tend to use 500 ml per meter square. A key hormone regulating water balance is the antidiuretic hormone, otherwise known as the vasopressin. The vasopressin acts in the distal collecting tubule, and the collecting ducts of the kidney to bring about retention of water by the body, so antidiuresis. And the two major stimuli, again, for the release of antidiuretic hormone are the rise in plasma osmolality and a decrease in the plasma volume. And so when the osmoreceptors in the body and the baroreceptors sense that the osmolality has gone up or the volume of effective fluid volume has decreased, the body releases more of antidiuretic hormone. It is important to know that other than these two physiologic stimuli, there are many other stimuli for the release of antidiuretic hormone in the body. Pain, stress, nausea and vomiting, hypoxemia, hypoglycemia, medications. Generally, when children are sick, the level of antidiuretic hormone is elevated. From the evolutionary point of view, it's been looked at that when people are sick, when people are in pain, they're not able to move to go and get water or get drink or get food or whatever they need. And so what the body does is that it decreases how much urine they make by increasing the antidiuretic. So whenever children are sick, even if the plasma osmolality remains the same, even if the plasma volume remains unchanged, the level of antidiuretic hormone goes up. It means those people are primed to retain water. They are primed to, and I want us to remember this point because it becomes important when we move down the road. And so the first question going forward is, what volume of fluid should I prescribe to a sick child. When I see a sick child before me, what volume of fluid should I be concerned about? Should I only be concerned about the maintenance fluid? More often than not, that is what we pay attention to. However, I'm going to introduce us or remind us of the parameters we should put in consideration whenever we are deciding how much fluid a child requires. Yes, we all know the maintenance fluid, which is the amount of fluid the body requires to maintain homeostasis. We should always, to preserve homeostasis, we should always calculate that, and we often do. But more often than not, we do not remember the deficit. Is the child dehydrated? If the child is dehydrated, in addition to calculating the maintenance fluid, we need to calculate the deficit fluid, or the fluid required to bring the person back to normal hydration status. And then the third component we need to factor in is, are there ongoing pathologic losses? Are there ongoing pathologic losses? If there are ongoing pathologic losses, then we also need to factor in. So whenever you are calculating the volume of fluid for any child before you, please calculate the maintenance fluid, calculate the deficit, and anticipate what the ongoing losses will be if they are pathologic, and make sure you provide all these three. If the child is not in deficit, then the replacement fluid is 0. If the losses are not the ongoing losses, so deficit replacement fluid addresses the fluid the child has lost before you examine the child. Ongoing losses reflects the fluid you think the child will lose going forward after your examination. So if you think the pathologic losses, if the losses going forward will not be excessive, then also the ongoing loss will be 0. So you just pay attention to the maintenance fluid. But some other times, you need to calculate all these, add them together to provide how much fluid you should give a child. So how do we calculate the maintenance fluid? We all know it, the Holiday and Seeger formula. This is one version we are commonly used to. The other version just tells us it's the same from here, but it's just telling us how much fluid we should give in an hour. So if a child, for instance, is 5 kg, we need to give 20 ml per hour per day. 20 ml per hour for the whole day. If the child, for instance, is 15 kg, 40 ml, the excess is 5 ml. So 2 ml times this is 10. So we need to give a 15 kg child 50 ml per hour to be able to make the maintenance fluid. That's the Holiday and Seeger formula. However, Holiday and Seeger came about this formula for healthy children. Children in whom the level of antidiuretic hormone in their plasma is not elevated. So what we said, when we are dealing with sick children, there are so many other stimuli for the release of antidiuretic hormone. And more often than not, their level of antidiuretic hormone is elevated. What that means is that their maintenance fluid may not be as high as it is suggested by the Holiday and Seeger formula that we are all used to. And so some other ways to calculate the maintenance fluid would be to get the person's body surface area and multiply it by 1,500. So if a child's body surface area is 0.5, that child will require approximately 750 ml as maintenance fluid. And if the child is not in deficit and has no anticipated pathologic losses going forward, the child would only require 750 ml. When the children are very, very sick, as more often that we have to deal with, and more so those children that we send to the ICU, we need to be very precise about their fluid. And a better way to do that is to look at their urine output. If they have NG tube or colostomy going on, to also look at what they are losing from there and add the insensible loss. So when we do that, we will not be giving them too much fluid or too little fluid. Let's remember that fluid overload is a major determinant of outcome when children are critically ill. And so we need to be much more precise about doing that. Remember, we talked about deficit, replacement fluid, and replacement fluid is actually trying to address dehydration. And so if the child is dehydrated, and we have so many parameters to assess that, however, just like we have said, if we serially monitor the weight of the child, that is a good marker, a much more reliable marker of the level of hydration. So also is the breathing pattern. If a child is having deep sighing breathing, most likely that child is severely dehydrated. And then the capillary refill. All this would help us in making a good judgment about the level of hydration, of dehydration. And so if the child is dehydrated, in addition to the maintenance fluid, we need to factor in the replacement fluid. So let's keep it in mind. 3 parameters we must always look at in determining the volume of fluid a child would require. And so this is just a further explanation of that. So if I have a child that is mildly dehydrated, that child still requires maintenance fluid. The maintenance fluid should be the usual diet the child is taking. If the child, for instance, is still an infant and is still breastfeeding, continuing breast milk will take care of the maintenance fluid of that child. And then you need to rehydrate the child. And if the child is mildly dehydrated and the dehydration is from diarrhea, then oral rehydration solution would account for that. And the ongoing losses, if the child is still stooling and vomiting, oral rehydration solution in 5 to 10 minutes would account for that. If the child is severely dehydrated, that same child has maintenance fluid requirement, has ongoing losses fluid requirement, and also has deficit fluid requirement. But because severe dehydration, for all intent and purpose, is similar to hypovolemic shock, we need to treat that an emergency. We need to resuscitate the child. So we give a portion of that deficit fluid as quickly as possible, sometimes up to 3 doses, and whatever is left of the deficit fluid is added to the maintenance fluid and given to the child over the remaining hours. So I just put this up to tell us that when calculating volume of fluid, the maintenance fluid, the deficit fluid or replacement fluid, and ongoing losses need to be accounted for. Then we go to an important point where we would end up with what type of fluid. We've talked about the volume of fluid we should use, what type of fluid. And before we reach that point, I will need to introduce or remind us of some concept. Osmolality. Osmolality is the concentration of the individual solute in a compartment. So if I take this to be a compartment, let's say plasma, the concentration, not amount over fluid volume is concentration. So the concentration of the individual solute constitutes osmolality, not the size. So even if I have another compartment that have big molecules like this, but the big molecules like this are only maybe 4, this and the total weight of here is probably more. This compartment has less osmolality than this compartment, because this compartment, the individual solute particles are far more than this. The movement of water between the extracellular compartment and the intracellular compartment, which we said is separated by the cell membrane, is determined by the osmotic gradient of the 2 compartments. In normal health, the intracellular is 280 plus or minus 10, the extracellular is 280 plus or minus 10. So there is no net movement of water. The solutes, most times we say cannot move, especially when they are charged or large. So it is only water that moves. When the osmolality of the 2 compartments are the same, there is no net movement of fluid between the 2 compartments. Osmolality can be measured, but commonly in practice, we calculate osmolality by the serum sodium level. The reason is that sodium is the most abundant solute in the extracellular fluid compartment, 140 millimole per liter. It is charged, it doesn't move away from that compartment easily. And because sodium is monovalent and positively charged, it means it has an equivalent amount of negatively charged molecules. Since we don't measure all those negatively charged molecules all the time, we will just make do that once we know the amount of sodium, we can estimate what the amount of negatively charged ions, called anions, would be. When we have uncontrolled diabetes with very severe hyperglycemia, that amount of glucose also exerts some osmotic property. And we can get that by dividing the serum glucose level in milligram per dl by 18. And we add it to this. So also when there is renal failure with very high urea, then if we know the urea level, divided by 2.8, that would also contribute to the osmolality. But in most children, glucose and serum level are normal when they are sick. So just knowing the serum sodium level and multiplying by 2 will give you an idea about the serum osmolality. Because sodium is about 140 in plasma, that's why we say the normal serum osmolality is about 280. I've been talking about osmolality. The osmolality determines the direction of fluid between the intracellular compartment and the extracellular. That may not be truly correct. The aspect of osmolality that determines the net direction fluid moves in is the effective osmolality. So the effective osmolality is the amount of solutes in a compartment, and those solutes do not cross the membrane, do not cross the cell membrane. Urea is not an effective osmolality. Urea can easily diffuse from plasma into the cells, meaning that over a short period of time, the urea concentration between the plasma and the cells equilibrate. And that is the reason why when we go for hemodialysis, and over a short period, quickly remove the amount of urea from the plasma, the cells become hyperosmolar compared to plasma. And as a result, drag fluid into the cells, including the brain cells, and that's why we have disequilibrium syndrome. So urea is not considered an effective osmol. Glucose is also not considered an effective osmol because in the presence of insulin, and if the patient is sensitive, responsive to insulin, even if you have high grams of glucose, very elevated grams of glucose in the plasma, over a short period of time, insulin is going to drive the glucose into the cells. And so glucose would not constitute an effective osmol, or what we call tonicity. So in essence, the direction of fluid movement between the intracellular compartment and the extracellular compartment is determined by tonicity, not just osmolality. And so if, for instance, the serum is hypoosmolar relative to the cells, it means that fluid will move from the serum, from the blood, from plasma into the cells. So let's keep that in mind because it is important. And that's what I have tried to explain here. This is the level of fluid in both compartments. The same, this is the intracellular, this is the extracellular. When the osmolality is the same, there is no net movement. However, if for any reason the serum osmolality drops, so here we have sodium that is 120, and if that is, we can estimate the serum osmolality to be 240. This is hypotonic relative to the intracellular fluid. It means in this patient, fluid is going to move into the intracellular compartment. So the extracellular will shrink in even the level of fluid, whereas the cells will get bigger, including the brain cells. Conversely, if serum sodium is very up, let's say 120, the serum osmolality is 320. In this situation, the serum is hypertonic relative to the intracellular. Fluid will move in this other direction. And so the cells will shrink in size, the serum and the interstitial fluid compartment would increase in size. If we relate this to dehydration, in hypernatremic dehydration, it means that those signs of hypovolemia you anticipate to see will not show up very early because fluid is moving from the intracellular fluid compartment to the plasma and to the interstitial fluid. So this child may have all the frank features of shock, probably when the fluid loss is more than 15% or even more than 20%. Whereas when serum is hypotonic, even small amount of fluid loss will exacerbate the symptoms because a good chunk of the fluid is also moving into the cells. But more often than not in dehydration, what we have is what we call isonatremic dehydration, where the serum sodium remains the same relative to, and the osmolality remains the same relative to the inter. So there is no net movement between the two compartments, only loss to the external. So sodium balance, like water balance, we gain sodium essentially from eating, no other way. When you don't eat, or when a child is mostly on what they call toast, or the other called toast and beer, they will become, that total body sodium will be low. So if a child for any reason is not getting enough food, is malnourished, more often than not, total body sodium would be low. We lose sodium through the same three means, mostly in our urine, our stool, and through the sweat. In health, the sodium requirement is estimated at 2 to 3 millimole per kg per day. We have taken this formula to now mean that when we calculated sodium to put into intravenous fluid, we have erroneously taken this formula to mean that this is how we calculate how much sodium that should be in the intravenous fluid we give children. No, this is oral. When people are eating from food and drink, this is the amount of sodium they require. Please, this formula is not for how much sodium the intravenous fluid you are going to give a child should contain. We'll make that point down the road. Sodium regulation, like water, the kidney plays a very huge role in sodium regulation. And the fine regulation of sodium takes place in the collecting duct. Here, only 3 to 5%. What we are saying here is that when the glomeruli filters sodium, sodium filters easily through the glomeruli. Remember, the glomeruli is a specialized capillary. So sodium moves easily through. So if you filter 1 liter of blood, 140 millimole of sodium will be filtered into the proximal tubule. Irrespective of the serum sodium, the proximal tubule will absorb 60% of the filtered sodium. The loop of Henle will take about another 25%, irrespective of the serum sodium, whether it is hyper or hypo. These areas of the kidneys don't respond to that. And the distal collecting tubule will take another 5 to 7%, such that by the time the urine or the filtrate gets to the collecting duct, we only have 3 to 5% of sodium left. This is where the body will now say, you know what, do I need to keep this sodium, or do I need to allow this 3 to 5% to be wasted? If the body requires sodium, it means the renin-angiotensin system will be activated. And when renin-angiotensin system is activated, one end result is increased level of serum aldosterone. Aldosterone interacts with this aspect of the kidneys to bring about reabsorption of whatever sodium is left. So if aldosterone is present, we would have less than 1% of this sodium. This 100% that was filtered by the glomeruli, only 1% or less will be lost. If the aldosterone is not present, then 3 to 5% or more of the sodium filtered will be lost. So the fine regulation happens here. When we talk about disorders of sodium is actually essentially disorder of water balance. In most cases, disorder of sodium or disorders of sodium are disturbances of water balance. It has nothing to do with sodium. So let me put it in another way. When somebody is hyponatremic, more often than not, the person has excess water than salt in the body. When the person is hypernatremic, more often than not, the person has lost more water than salt. So more often than not, when we are correcting sodium disturbances, we tend to be more focused on the water aspect and not necessarily the salt aspect. Hyponatremia, which is serum sodium less than 135. I've put it 135 because we see all sorts of lab results. Some will tell us that hyponatremia in their lab is serum sodium less than 130. Some will say it's less than 133. What that tells us is that those labs have issues with quality control. Quality control. So when you look at lab results and they're telling you that their reference range is less than maybe 130, 133, in the back of your mind, you should know that that lab has issues with quality control. The normal serum sodium is 135 and above. Any sodium less than 135 is considered hyponatremia. And if you just take a quick look at your patient's result, even the patients under your care today, you'll find that the most common electrolyte disturbance you will find is actually hyponatremia. And so that's what I will focus on. I won't talk more about hypernatremia. More often than not, what we find with hyponatremia is that a dehydrated child got the fluid that he or she has lost replaced with hypotonic fluid or with pure water. So somebody that is dehydrated, maybe from diarrhea, where he or she is stooling, passing both salt and water in the urine, the dehydration is replaced by hypotonic solution, sometimes intravenously. Commonly, that is so. Less commonly, it is because the person has lost more sodium. But more often than not, the reason is because the person has more water or replaced the fluid and electrolyte lost with fluid and electrolyte that has less sodium than what he or she lost. Biochemically, hyponatremia may be classified as mild, moderate, or severe using these parameters. More often than not, people are symptomatic when the sodium is less than 125. But in clinically, we only have two categories of hyponatremia. Either it is moderately severe or it is severe. When they have nausea without vomiting, they have headaches and confusion only, we consider that hyponatremia to be moderately severe. But by the time they start vomiting, their level of consciousness become altered, then we consider that hyponatremia severe, and we need to do something about it. Because sodium is the major contributor to serum osmolality, hyponatremia in most instances also reduces the osmolality of the plasma. And so when people are hyponatremic, their serum osmolality is low. Because the serum osmolality of the cells is high, water is going to move from plasma into the cells, from the interstitial fluid into the cells. So the cells will get bigger in size. That's not a problem for the cells of the skin. That is not a problem for the cells of the muscle. But the cells in the brain, they have a problem because surrounding the brain is the hard skull. And so when this brain swells up, then it reaches a point where the pressure inside the cranium increases. And so almost all the symptoms and signs of symptomatic hyponatremia are signs and symptoms of raised intracranial pressure. We could also classify hyponatremia into acute or chronic, and this is important. The reason why we make this distinction is that acute hyponatremia can be corrected quickly. It is the chronic hyponatremia that we have serious problems with correcting. And so let me explain it. So for this, let's take this to be the brain cells. This is the brain cells. And so this patient is this patient is hyponatremic. It's hyponatremic. Fluid moves from the plasma in the interstitium into the brain cells. So the brain cells get bigger. But usually over 48 hours, the brain cells start losing some of its own osmol so that it can reduce its own osmolality. So the brain cell starts losing some osmol, so that its own osmolality can come lower, maybe to 260, so that at least it will drag less fluid from the interstitial compartment and from plasma. When we now rapidly tend to correct the hyponatremia, if we now rapidly increase it, for instance, over a short period to 140, it means the osmolality becomes 280, and then the plasma becomes more hyperosmolar relative to the interstitial fluid. And what that means now, it means the interstitial fluid will now be dragging fluid this time around away from the brain cells. And there are many cases of what we call pontine demyelination, a permanent, almost irreversible brain damage occurring because of this rapid correction. And so that's where the concept of acute and chronic comes about. If you do not know how long it took for this hyponatremia to occur, please assume that it is chronic, and you need to be very, very slow and deliberate in your correction. Talking about the causes of hyponatremia, there are many, but the 2 points I want to make is the use of hypotonic intravenous fluid and syndrome of inappropriate antidiuretic hormone secretion. So let me, for the first point, I've touched on it before, but this is an editorial from New England Journal of Medicine, 2015. And the editorial stated that most hyponatremia in patients is hospital acquired, essentially saying is iatrogenic. Doctors are responsible for it. And it is related to the administration of hypotonic intravenous fluid in patients with elevated anti-arginine vasopressin level. Remember, I said when children are sick, there are many other stimuli for the release of antidiuretic hormone other than increase in plasma osmolality or decrease in plasma volume. So because of that setting, when children are sick, they tend to retain more fluid from their kidney, more pure water from their kidneys. And so if you give them fluid that is hypotonic intravenously, then you are likely to push them into hyponatremia. And so virtually all studies that have looked at hospital-acquired hyponatremia have reached the same conclusion, that it was due to the administration of hypotonic fluids. And so the question that will be running through your mind, which intravenous fluid is hypotonic, which one is not hypotonic? And in those polls that we ran, we're trying to test that. The other point I want to make, because pediatricians are particularly very scared, so sometimes inappropriately scared of syndrome of inappropriate antidiuretic hormone. So virtually everybody, even the child that is dehydrated, is assumed to have syndrome of inappropriate antidiuretic. That is not correct. Syndrome of inappropriate antidiuretic hormone occurs whenever antidiuretic hormone is released from the posterior pituitary by stimulus or stimuli other than decrease in plasma volume or increase in plasma osmolality. So whenever this hormone is released by the brain and the stimulus for that is not decrease in plasma volume, you cannot say the patient has a syndrome of inappropriate. If it is not due to increase in plasma osmolality, you can. And so what it means is that it is unusual. Because when patients come to us and they are dehydrated, then the release of antidiuretic hormone in that setting is appropriate. It is not inappropriate. And so they cannot have syndrome of inappropriate antidiuretic hormone when they are dehydrated or when their serum sodium is normal or even increased. Again, just to make the point, there are essential criteria before you say somebody has syndrome of inappropriate. One, they must not be dehydrated. So we need to remember that point. So when patients come to us and they are dehydrated, please, they do not have syndrome of inappropriate antidiuretic hormone. Again, what this slide is also telling us is a diagnosis of exclusion, meaning that we should not always be in a hurry to label every hyponatremia we see as syndrome of inappropriate antidiuretic hormone secretion. I won't go into too much points here. This is just a template I use in deciding what might be the cause of hyponatremia in a child. So I look at the level of hydration. If the level of hydration is decreased, then I'm not expecting to see syndrome of inappropriate antidiuretic hormone. And if I look at the level of hydration and I make a judgment about it, then I measure how much sodium is in that urine. We get, when we send some of these requests, most times to our lab, they tell us, oh, they cannot measure, they cannot measure, they cannot measure. But if you push them well enough, that with the same machine they are having, they can measure sodium in that urine, then you might be able to get them to do that. Again, using this, you can make a judgment, reduce the differential, but I won't spend so much time on it. Hyponatremia, like we saw in the clinical classification, is not, there's no mild hyponatremia. Hyponatremia is either moderately severe or severe, meaning that it is not a benign condition. And so we need to be on the lookout in management. Most cases of hyponatremia do not need any direct treatment of the hyponatremia. You just need to address the underlying cause of the hyponatremia. However, when it is severe, especially less than 120, and when they are symptomatic with seizures and alteration in level of consciousness, then a rapid increase in their serum sodium by as much as 5 milliequivalent may take care of the symptoms. So it's not totally to correct the hyponatremia, but it's to mitigate the symptoms so that over a longer period of time, we may not correct the sodium level. Additionally, if they are, for instance, hypervolemic, remember we said disturbances in sodium, more often than not, is disturbance in water level, water balance. And so if a child is hypovolemic, hypervolemic, and hyponatremic, then I want to look for means to make sure the person loses the extra fluid he or she has. If somebody is hyponatremic and also hypovolemic, then if I resuscitate that person with fluid, normal cell line, I may be able to correct it. If somebody is euvolemic, is not dehydrated, and is not hypervolemic, and has hyponatremia, then restricting fluid, like we will do for syndrome of inappropriate antidiuretic hormone secretion, may treat that. No matter which method you take, we do not want to correct the serum sodium level faster than 0.5 milliequivalent per hour or 10 to 12 per day, whether it is hypernatremia or hyponatremia. And a good guide is for you to frequently monitor the serum sodium level, sometimes every 6 hours, so that you do not overcorrect. Most times it is the overcorrection that carries a lot of danger. And so these are some of the formulae for correction of sodium imbalance. Maybe I should just make a small, let me put a diagram and see if I can explain some points when it comes to this. If we take the body to be one whole compartment, this is total body water, which we already know is, if we know the weight, we multiply it by 0.6. The weight multiplied by 0.6 for most of the children we deal with, multiplied by 0.6 to know the total body water. If somebody's serum sodium level is 140 millimole per liter, it means for every 1 liter, the person has 140 millimole of sodium. So if, for instance, this child is 10 kg, this child has 6 liter total body water. And so if this person's serum sodium is 140 millimole per liter, it means the total amount of sodium in this child's body is 140 times 6. And that would be like 840. So this child whose serum sodium level is 140 and is weighing 10 kg has 840 millimole of sodium. Okay. If that same child has a serum sodium of, let's say, 120, it means the total amount of sodium in this child, 10 kg, is 720. It's 720 millimole of sodium that is dissolved in 6 liters of water that made the serum sodium to be 120. So if it means that if I want to raise the amount of sodium to 140, if I want to raise the amount of sodium to 140 in this child, essentially it means that I have to increase the total bodies. The total 2 ways I can do it is to either increase the amount of sodium to 840, still in 6 liters, still in 6 liters, or I would have to reduce the total body water. So if the person is hypervolemic, then the aim is to reduce the total. So I want us to look at it from that compartment. If we look at it from that way, then we can always decide how much what is equal, how much we want to do. So let me, for instance, clean this slide again and see if we can, okay, so let me clear all drawings. Okay, so I have a child, 10 kg, serum sodium is 120. My plan is to raise it to 140. 140. We said this child's total body water, which we calculated to be 0.6 times the weight, 10 kg. We ended up with 6 liters. And so this person has 720. If I want to increase it to 140, means I need to increase the serum sodium by 20. But in doing that, I will be using fluid. So that fluid I will be using would also be providing some water. Maybe when we come to some examples, I'll do that more clearly. But please look at the body, the serum sodium as part of the total body, just the way you would describe any compartment, amount and concentration. It depends on the amount and it depends on this. So if I want to raise this person's serum sodium to 140 now, that has 6 liters of water, then I want to decide how many particular fluids. So if I'm using, for instance, normal saline has 154 millimole per liter of sodium. So I want to ask myself, how much of this will I use to give this patient to increase the serum sodium to 140? And because it comes in 1 liter, that means that the total body water would also increase by the number of liters I give this patient. It doesn't tell us over what duration. Over what duration you should give. We clearly say we do not want to raise it more than 0.5 milliequivalent per hour per day. That's between 10 and 12 milliequivalent. What this formula is showing us here is how we can do those things. how much, if you eventually decide on the fluid you are going to use, the type of infusion you are going to use, whether it is normal saline or whether it's 3% saline or whatever fluid concentration you want to make, you need to factor in that how many liters do you need, how much it will change. And this formula will help you to decide on the rate you want to do. We can do some practical example, and if we have the time, I could just go through a video that would clarify this. So that brings us to the question, what type of intravenous fluid to give? Intravenous fluid to give. Like I said when I started this presentation, is that this is one aspect of medicine that has a lot of hard evidence, a lot of high quality randomized control trials, and even several meta-analysis, all pointing in the same direction. And so let's go through some of the commonly used fluid we have. Please note that the fluid here I'm discussing is for when we need to give maintenance fluid intravenously. When we need to rehydrate patients, then we need to factor in mind what type of fluid the patient has lost, and we may need to make specific decision on that. However, if they are severely dehydrated, the initial fluid we need to give them should be fluid that we know will rightly stay in the plasma and the interstitial fluid compartment, and not fluid that would easily move into the cells. So let's look at hypotonic fluid. Please note that the point here is tonicity. Tonicity. This is serum. This is the amount of sodium in serum, chloride in serum, lactate or bicarbonate in serum, and glucose in serum. The osmolality, like we said, is about 280. When we take 5% dextrose water, it doesn't have any sodium, doesn't have any chloride, no electrolyte, only glucose. In vitro, the lab, the osmolality of this fluid is 252. You will say not too bad compared to serum. However, when you infuse it intravenously, this is what happens. The body produces insulin, and insulin over a short period of time drives most of the sodium and most of the glucose into the cells. What you're left with is pure water. And so what you're left with in the serum is actually a fluid with little or no osmosis. And so you end up diluting the serum of such a child. If we give what we call pediatric saline, and that's what most of us were taught in school, and it came from the Holiday and Seeger experiment and the rest. They decided some 50 years ago that this was the ideal fluid for children. Here is 1/5 of normal saline. So the sodium level is this is the chloride level. With the glucose, you can see that the osmolality is well within that of serum. Perfect, you would say. However, please note that this is in the lab. When this is infused, insulin, in the presence of insulin, this glucose disappears. So what you're left with is only 61.6 milliosmol per kg of osmol as the osmolality. So this fluid is hypotonic. In the lab, it is isotonic. But once you infuse it, it becomes hypotonic. Let's look at 5% dextrose in half normal saline, which is increasingly being used in a lot of practice. Half of normal saline, and so with some glucose. And so we end up with a fluid whose osmolality is 406, almost 1/2 times the osmolality of plasma. You may be tempted to say this fluid is hypertonic. However, we know that once it is infused into the body, the whole of the sodium goes, glucose goes, so we're left only with this. So only with a serum, an osmolality of 154. You're diluting the serum osmolality. And what that means is that if we take this to be the cells and here to be the plasma, you are ending up with a fluid that the osmolality is less than 280. And so as a result, a lot of fluid will be moving into the cells, and in the brain, this will cause brain swelling and a lot of complication. Secondly, because this fluid easily moves out of the plasma and out of the interstitial fluid, they are not effective for resuscitation. So when you are treating patients with shock, for instance, you want to rapidly increase their effective plasma volume, then this fluid, because they are hypotonic, even though outside the body, they may be iso or hypertonic, are not ideal. It also means that when we are giving maintenance IV, maintenance fluid intravenously, please, we should avoid fluid that are considered hypotonic. We may say, what is the evidence? I would show that later. The fluid on the green, with the green column, are fluid we consider isotonic. We know normal saline, and this is normal saline. The osmolality is 308, slightly above. And that's why normal saline is an effective resuscitation fluid. Because when you give it, if anything, the serum osmolality goes up a little. And so you are able to rapidly, over a short period, expand the plasma volume. Ringer's lactate, on the other hand, is isotonic. It's isotonic. So when you give it, you're not going to lose a big chunk of the fluid you've given into the cells. It's going to stay in the plasma and the interstitial fluid. Because children, we don't want children to go into ketosis. We always, for maintenance fluid, provide children with some glucose. And so it is important we give glucose. And we all know how to do this. If I have normal saline, luckily the normal saline, we have commercial 5% dextrose in normal saline. The Ringer's lactate we have does not have glucose. We tend to add glucose to it. By adding 50 mils of 50% dextrose water to every 500 mils of Ringer's lactate, we've converted that Ringer's lactate to 5% dextrose in Ringer's lactate. So look at this. We say it's quite ideal. Here, the osmolality is this outside the plasma, outside the body, but immediately you give it, this glucose is taken out, so you are left with almost 275. Increasingly, evidence is coming, and so the point we're making is that if you must give IV, if you must give your maintenance fluid IV, please give isotonic fluid. Avoid hypotonic fluid in most children that you will deal with. More so in sick children where the antidiuretic level, hormone level is already elevated. Remember, antidiuretic hormone only keeps water, pure water, from our urine. It doesn't keep salt. And so if you are giving somebody hypotonic solution and the person already has high levels of antidiuretic hormone, which we expect in sick children, you are worsening their risk of water toxicity. Let's look at normal saline closely. The sodium level in normal saline is above what we have in serum. Secondly, the chloride level is supraphysiologic. And because chloride is negatively charged, it competes with other negatively charged ions like bicarbonate. And so if we load patients mostly with normal saline, it is common that they end up with metabolic acidosis. And studies are beginning to show that giving large amount of normal saline for maintenance fluid, because of the high level of chloride it has, predispose children to not only metabolic acidosis, but to acute kidney injury and adverse outcome. So please, outside the resuscitative period, we would prefer you give children what we call balanced fluid. And a balanced fluid is typically this in our own environment. Outside this country, they'll talk about plasma light. But this is our own plasma light by adding what is it called, glucose to it. It is considered more physiology. And yes, we call normal saline, but data is beginning to appear that normal saline may be considered abnormal saline. So data is beginning to appear that normal saline may actually not be ideal for maintenance IV fluid. Remember, for replacement, especially in management, the early phase of management shock, normal saline and Ringer's lactate are recommended fluids. And so this is some of the evidence. Here we have almost 10 studies, and you can see most of the studies are on the same side. Most of the studies are on this side, favoring giving isotonic fluid as maintenance when you require IV fluid therapy. Please, let's use isotonic fluid like normal saline, like Ringer's lactate, and in children, the ones we add glucose to it. This is it. So hyponatremia is unusual if we use isotonic fluid. It is much more likely to occur if we use hypotonic fluid. And this is what I was saying, that there was no difference from one study to the other. So the heterogeneity was zero in these studies that were included in this method. The fear for most of us is that using isotonic fluid may cause hypernatremia. Again, the evidence does not support it. When we use isotonic fluid for maintenance therapy, the risk of hypernatremia is not that elevated compared to giving hypotonic fluid. And what this slide is telling us, that is not only in surgical patients, but also in non-surgical patients, and most of these studies are in children, mind you, shows that giving isotonic fluid is preferred. So yes, for a long time, for almost 5 decades, we all were comfortable using 4.3% dextrose in 1/5 saline as the preferred maintenance IV, not oral. If you need to give oral, the normal food and drink the person takes would make for it. But if you have to give it IV for any reason, then the evidence is that we should use isotonic. For us in LUT, we started that transition sometime in 2010. It took us several years before everybody got on board, but it's unusual for us to find 4.3% dextrose in 1/5 saline. In most developed countries of the world, even the production of that fluid has been halted. Production of what we call pediatric saline has been halted. And I guess we will get there in Nigeria if every one of us stops using hypotonic solutions like 4.3% for empiric maintenance intravenous fluid. So, and this is from the NICE guideline. The American Academy of Pediatrics have provided a almost similar guideline. That routine maintenance intravenous fluid for children, even in term neonates, this is from UK, even in term neonates, should be isotonic and should contain glucose. Isotonic fluid, they reckon, is a fluid that has sodium between 131 and 154 millimole. Term neonates with respiratory distress syndrome, with meconium aspiration syndrome, perinatal asphyxia, should receive sodium-free intravenous fluid until diuresis and postnatal loss, so maybe like up by day 3. But if the children do not have some of these very severe illness and they are otherwise, require IV fluid, please, we should give them, even if they are neonates, that's what the evidence suggests, we should give them isotonic fluid. A critical, this thing is our patients with sickle cell with vaso-occlusive crisis. When they come in painful crisis, what should we give them? Because we know that intracellular dehydration promotes sickling. So what fluid should we give them? I looked up the literature, no consensus, but most people will still give fluid that have maybe 0.5% saline or 0.6% saline. But the evidence there, I think, still needs to be worked out. So here, what I'm trying to show here is that ongoing losses, the fluid we use in replacing it should be what we expect to be in the pathologic losses. So if people are vomiting, they may be just vomiting. They'll be losing a lot of acid, a lot of chloride, they'll be losing a lot of sodium and a lot of potassium. And so when we are replacing such fluid, we need to pay attention to that. If they have diarrhea or colostomy, so they may be losing up to 140 millimole per liter of sodium for every liter of fluid they lose, and 30 to 70 for potassium, and almost similar for bicarbonate. So that brings me to almost the last aspect of the presentation. I'm talking about oral rehydration solution, which we need to make more use of. In time past, until some few years ago, this was the type of ORS we had in Nigerian market. And this ORS has this amount of sodium, glucose, and the osmolality was more than that of serum, more than that of the interstitial fluid. And when parents complain to us that their children tend to stool for longer periods when they were on ORS, we did not believe them. But look at the evidence. Serum osmolality is 280, and then the osmolality of the fluid we are giving them in the intestine is 311. And so what that meant that we were actually dehydrating them in a way, pulling some fluid out of the cells into the intestine, and this fluid was being lost in the stool. And I think the WHO quickly realized that. And so more recently, they reduced the amount of sodium and glucose in the fluid we have, such that the osmolality in ORS is less than what it is in plasma. And so as a result, fluid can easily move from the intestine into the cells. Concerning the ORS, I just need to make a point that we are having different brands in the market. So the one size instruction we give caregivers to say, mix 1 sachet in a liter of water may not always be true. We have the ones that you have to mix only 200. We have the tablets one, that you just drop a tablet in a glass of water, and we have various brands coming up in the market. So we need to pay attention when we are giving parents instruction about ORS, and we need to use it more frequently. When children come in dehydrated, even if they are vomiting, you may try and give them some fluid while they are in the hospital orally. And by the time you know it, they may be able to tolerate more. There are also flavored type that is making it more enjoyable for the children. So in terms of conclusion, fluid and electrolyte disturbances are common when children are sick, and we need to pay more attention in deciding what the volume of fluid is and what the type of fluid is. What I did not go into detail is how rapidly with which we need to give it. How rapidly we need to give it, there is no consensus about it. But what is more important is that whatever method we choose, we need to, examine the patients a little bit more frequently and make adjustments. Hyponatremia is common, and even mild forms are not benign. And most times they are caused because doctors are giving patients intravenous hypotonic solution, and we need to avoid that. We've seen the reason. And so the take-home message is that when we must give maintenance fluid as intravenous therapy, hypotonic solutions should be avoided. An isotonic solution is a solution whose sodium is almost close to that of serum. Thank you very much. I will take questions, comments, and as the case would be.
Thank you very much, Professor Esezobor, for this wonderful presentation. I think this is a box movie sellout. We never really had this number of participants hanging on till the end. Usually the meeting runs for about 1 hour, but 1 hour, 50 minutes we are on, everybody's glued on. And just to know that we had lots of people wanting to enter into the chat, the presentation, and we couldn't accommodate them because we had reached capacity. For once, we have really bust the charts here. So we really want to thank you very much and congratulate you. And a big round of applause from all of us who have listened to this wonderful presentation from you. I will now, well, time is far gone, but I know there are many questions that people would want to ask. We'll indicate by raising up our hands, unmuting our mics, and asking the questions. So please, questions, please.
I guess I was the one that was logged out.
Sorry?
I think I went out briefly.
I see, okay. But did you hear what I said?
I heard some, but not sure I heard everything.
Everything. So, well, more of
Okay, so maybe is there room for me to take questions? Is there room? Dr. Dudu.
Yes, somebody's hand is up. Somebody's raising his hand up there.
Okay. Dr. Amin, can you unmute? Or do I have to do it?
great. So we're giving room now for questions.
Hello?
I had the technical glitch on my Chris. Can you hear me?
Yes, we can hear you. So we have moved on. We're asking
Okay.
Dr. Amin to ask.
Very well then.
Dr. Amin, can you? Yes, go ahead, please. You have the floor.
Good afternoon, sir. I want to say good afternoon to everyone on the meeting and to also appreciate Professor Esezobor for the excellent presentation. I have a few contents here, so I'll just read them out. So I want you, sir, to clarify the difference between osmolarity and osmolality. Okay, so you only mentioned osmolality. So I want to know the difference between osmolality and osmolarity. So that's number one. Then number two is the fact that a very important aspect of your presentation was that sick children usually produce antidiuretic hormone. Okay, so does it mean that SIDH cannot be diagnosed in sick children? Because we know that you mentioned that you emphasize that sick children usually produce antidiuretic hormone. Does it mean that SIDH can only be diagnosed in LD children? So that's so I just need clarification on that. The second point. Okay, the third one, I think you have addressed that. The role of 10% dextrose water in units, which is our usual fluid for newborn babies. So I just wanted to know, I think you alluded to that, I think at the later part of your presentation, that that's an exception to, because I was just wondering whether 10% dextrose water in the units, is that not pure water? Because knowing fully well that the fluid, the glucose content will be transported or would migrate into the intracellular space after infusion. Because are we not giving the unit water? But I think you mentioned that is an exception during the later part of your presentation. So thank you very much, sir.
You're welcome. So, Dr. have the floor.
Thank you very much, Prof. Esezobor, for an excellent delivery as usual. I was actually hoping that you could give me more information on that HBSS, when they're in crisis, because there's a lot of contention on it, but it looks as if you didn't see much on it. So, like, which fluid would you, from all the physiological discussions, which fluid may you prefer or suggest for HBSS in crisis? Thank you.
Thank you very much. Dr. Nena.
Thank you very much, sir, for the wonderful presentation. Talking about the concern of worsening dehydration from hypertonic oral solution, can one also be concerned about the kind of oral fluids that mothers may use to rehydrate their children, particularly in mild or moderate dehydration from diarrhea disease, not just from ORS, but other fluids like some of these drinks out there that may contain some solutes that may make the fluid osmolar, highly osmolar to the guts. Thank you, sir.
So thank you very much. I can't see hands, but there are some questions that have been put on the chat box. Faith said, you mentioned that neonates without asphyxia, meconium aspiration should be given isotonic fluid. Does that mean that even within the 24 hours of life, what I've always known is that they are giving 10%? So I think let me start from that. So that's what we've always been taught. But we have evidence, and like I showed you, the NICE guideline is what is like the highest body, evidence producing body in the US, in the UK, that gives guideline. Even so, the reason for that is that we generally contend that neonates, especially in the first few days of life, have problems with, one, they are making the transition from, they're trying to lose some fluid. They're also trying to make the transition from extracellular fluid compartment, which is the most dominant in the fetus, to the intracellular fluid compartment being the most dominant. Second, they have issues with their kidneys in handling both fluid and electrolyte. So glomerular filtration is actually very, very low in the first few days of life. And so traditionally, because of that, we tend to avoid salt, fluid containing sodium, and tend to give them small amount of fluid. However, the evidence suggests that if you are not dealing with critically ill children, like the meconium aspiration, the perinatal asphyxia, that even in the first day of life, those children should be given isotonic or not hypotonic fluid. And so that's what I said about that. Osmolality, if we go by calculation, one is dividing by kilogram of water, and the other one is dividing by liter of water. Irrespective of it, osmolality does not determine the net direction of where fluid moves between the intracellular compartment and the extracellular compartment. What is important is the concentration of effective osmoles, those osmoles that do not move, that do not cross the membrane. So whereas osmolality is a big family, has everybody under it, including urea, including glucose. However, tonicity only would include those osmoles that are not going to move. So for academic purpose, one is you divide the amount of the solute by the kilogram of water, and the other one you divide by the liter of water. However, it plays no role in the net direction of fluid. Concerning syndrome of inappropriate antidiuretic hormone, This is the way I like portraying it. You have syndrome of inappropriate antidiuretic hormone whenever antidiuretic hormone is released in the absence of either of the two physiologic stimuli. One of them is increase in plasma osmolality. The second stimulus is reduction in plasma volume. So whenever these two stimuli are absent and you have release of antidiuretic hormone from the posterior pituitary, that release is inappropriate. That's the point I was making. I went on to say further that when children are sick, they have a lot of other stimuli for the release. So when children are sick, it provides a setting for them to easily develop syndrome of inappropriate antidiuretic hormone because they have so many other things like pain, nausea, vomiting, hypoglycemia, hypoxia, emotional distress, medications, even just going for surgery are all stimuli. But because they are stimuli other than those two, they would predispose a child to syndrome of inappropriate antidiuretic hormone. The 10% dextrose water, I think I've explained it. The evidence is that even in the first day of life, term units, not preterm, term unit, where without things like perinatal asphyxia, where their kidney function is further compromised, without meconium aspiration syndrome, that puts a lot of stress on even the transition from fetal to adult circulation, these children should be given isotonic solution. 10% dextrose water outside the lab is hypertonic, but when it is infused in the body, it's a hypotonic solution and it should readily be avoided. Concerning the vaso-occlusive crisis, I went on specifically to look at it because we see these patients very frequently in the emergency room. What we have continued to do in our center most times in the emergency room is to just still give everybody isotonic solution. However, some unsubstantiated evidence, some expert opinion is that they may benefit from solutions such as 0.45% saline or sometimes 0.7% saline, just to create some hypotonicity and encourage fluid to move into the cells. There is no randomized control trial to say this is the best for that, but I think it is something we need to look at and consider. I want to thank the person that talked about the fluid our parents are using to rehydrate their children when they are dehydrated, well, when they are losing a lot of fluid. We need to agree, we need to pay a lot of attention because we hear all sorts of things. Sometimes we hear 7-Up, Sprite, Limca, that it is similar to ORS. They are not similar. Even sports drink are not similar to oral rehydration solution. So when children are stooling and vomiting and do not require intravenous fluid, then oral rehydration solution should be used for two things. One, to correct the deficit they already have, mild, moderate, and two, to prevent further deficit by making sure we account for ongoing losses. It is important we tell the parents that if the child does not, after they've corrected the dehydration, if the child does not pass loose stool or vomiting, the child does not need to continue to drink the ORS. The child should take his or her normal fluid and other drinks. But for every time the child passes loose stool, because sometimes when we give the instruction to those parents, especially more so in most of our centers, we no longer have need for diarrhea units. In the 80s, there was abundant reason for diarrhea units where we used to do salt sugar solutions and not the rest. Some of our centers don't see any need for that again, which I think is appropriate. But if your center is such that you see so large number of children with diarrhea, then it's appropriate you still maintain your diarrhea unit. And in that diarrhea unit, you need to teach the parents carefully. Yes, if they are going home on ORS, the ORS is to correct any deficit, and they should only use it when the child has ongoing losses. If the child does not have ongoing losses, please, the child should eat and drink their normal food. Otherwise, that child may become hypernatremic. I see some questions on Kushimo, talking about, I've seen centers use half-strength Darrows. Yes, half-strength Darrows, 50% dextrose water, used to be the practice when I was still in medical school. And even when I graduated, it was there. Please, like you said, you have not seen it in any literature. So please, so much potassium. You see, we talked not so much about potassium in this lecture. Not that because potassium is not important, and ideally, especially when we are giving balance, and that's why we prefer Ringer's lactate to normal saline for maintenance IV fluid. Yes, potassium is important, but we do not need potassium. If you check the potassium in people even use full strength Darrows. Yes, those practices came when diarrhea were killing a lot of our children, and when oral rehydration solution had not become widespread. But there is no room for that. And I think in most places, such solutions will actually not have license to be manufactured, but that is not the case in our own environment. Daniel was talking about on the chart, Daniel was talking about, I want to know if there's any attempt or effort to give feedback to the healthcare. I think the first stage is what we are doing. The first is so to change things. I gave example of our unit, of our department in Lut. It took us almost 4 years from 2010 to 2014 to get everybody to be on the same page, to agree. If you take from the poll we ran, you could see that in some centers or in some practices, 4.3%, even in teaching hospitals, pediatric units in Nigeria. So that is the first step we need to do. And that's why I want to thank the organizers of this meeting for providing a platform. Because if we all become convinced that empiric use, maintenance IV fluid, hypotonic solutions like 4.3% have no place, and we stop prescribing them, then the, what is it called, the manufacturers would naturally actually stop manufacturing them. For us in our hospital, even when we got everyone on board in pediatrics by 2014, we still found that the surgeons, the pediatric surgeons, whenever they had patients in our ward, or whenever they took our patients to theater and sent the patient back, they were prescribing 4.3. It took a lot of talking before they finally changed their practice. So it's going to take time for practice to change. But I think we've started the right course. If we, in South Africa, that fluid has been banned. In UK, it has been banned. In many other developed countries, there's no license to produce such fluid. Yes, it emanated from our previous knowledge, what Holiday and Seeger came about, but we have evidence to show that the fluid may actually be dangerous. So yes, it's going to take time to do that. Let me see, in addition, the fluid is used in neonate. Wow. So you need to engage them and you need to provide them evidence. People using half-strength Darrows in neonate must be very brave. You need to provide them evidence why that should not be. So I want to stop here and thank Dr. Mobolaji Lawal for creating this platform. And I'm sure this platform is going to go places, and many more states in Nigeria would see the need to harness the potential of the pediatricians in private practice. They see the biggest chunk of the population. We in teaching hospitals are actually supposed to be heavily on training and research. So thank you very much. I want to thank Dr. Eletu, Dr. Uwaje, and I hope I have paid my dues. Thank you very much.
Thank you very much, Dr. Esezobor. Brother Esezobor. Thank you very much, Esezobor, for this presentation. Like I said earlier on, this is one of the longest and the most attended presentation we have had. Just before we go on, just to say that many people are desirous to have a copy of this presentation. Know that this presentation is on YouTube and will be widely distributed in the YouTube format so that people can listen again to this wonderful presentation and get educated. Dr. Fajolu is supposed to make the closing remarks. I wonder if she's here. I've checked through the list of participants. I cannot find her. Dr. Fajolu, I don't know whether you are using another device to log in, but if you are in, then you can go on to indicate as such so that you can make the closing remarks. Well, if she's not here, then I want to again thank Professor Esezobor and all those who have participated in this session. Thank you for your patience. I'm sure it was really worth the while waiting all this while to enjoy this wonderful presentation. As our usual practice, I go back to Dr. Mobolaki Lawal for the final remarks before we all depart to our various other activities. Thank you very much. Dr. Mobolaki Lawal, please.
Well, thank you very much, Dr. Dudu, for excellently managing this program. And our speaker, he decided to thank everybody before we thank him. So we really thank you for the compliments you have paid to the group on days such as this. The importance of this group becomes more and more evident, because there's need to change. There's need to use evidence to change practices. And I think the presentation of today, especially coming from a very erudite professor, has clarified quite a few things for members of this group and so many people that joined. So I thank you very much, our speaker, Professor Esezobor. I'm sure the committee may be calling on you some other time. And to all those who have patiently stayed on, I thank you all for coming. We operate this program every month, and you'll be seeing the link, the invitation from the normal channels that you have seen them. And it's also on YouTube. So if you missed anything today, you can always find anything that you missed on YouTube. So thank you very much. Over to you, Leo, to close.
Very much, sir. Once again, thank you very much, Professor Esezobor. So with this, we'll call the meeting to, a close for the day. I'll look forward again to see you next month, where we'll be having another very interesting presentation that will hold us spellbound as this one. Thank you very much and bye-bye.
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 I want to frustrate my first attempt to wax my first record. Every time I see me struggling, the way that took off at the very crucial time, took it off. If not, Lona was standing by me. It was nice. I know because I was waiting to admit in the room. Admit. People were kept wanting to enter. Yeah, okay. Are you serious? I do a lot for the exams and everything.